about, I guess now 13 years ago, and I was a stranger in a strange land. I had come from the world of software development, where the usual attire was t-shirts and jeans, and the only tradition was to not stand on tradition. In fact, our three most influential role models, Gates, Jobs, Zuckerberg, were all college dropouts. And there I was, pursuing a PhD to figure out how to make software work in healthcare. And on this particular day, I was at the UCLA Medical Center, sitting across from a urologist, discussing potential project ideas that we might work on together. Now, he knew that I had something to do with computers, and if my high school Latin hadn't failed me, I knew that a urologist was a specialist in urine. Or probably the bladder. Neither of us had any idea what the other one did, and yet there we were, talking about a project that we might work on together. And it went something like this. He said, imagine if your father had prostate cancer. And I really appreciate the extra effort he made to personalize the story. He said, if he did, and we decided to remove the prostate surgically, then his job, first and foremost, would be to remove all of the cancer. But in doing so, he'd have a very important decision to make during the operation. See, on either side of the prostate are nerves. And if he removed both the prostate and the nerves, then odds are he would remove all of the cancer. But in doing so, removing the nerves may lead my father to be incontinent or impotent. And here's the catch. He said, we don't know which is the right decision. And that, he said, is where I would come in. See, I could write software that we could use to understand what was really happening and then relate this to outcomes, and then we would know which is the right decision to make. So I was as flattered as I was confused. I asked first, are you sure we don't already know the answer to this question? And he said, no. Despite the fact that we've been doing this surgery for over 60 years, in more or less the same way, we haven't done the math on this. Well, my second question was, regardless of how important this problem is, are you asking me to query a database? Because I knew that my advisors wouldn't go for me doing a dissertation that involved writing a couple queries on databases. And he said, that's just it. There is no database. Everything we know about what happens during surgery is captured in the free text operative report. It's dictated by the surgeon following the surgery, so we can't do the math. All right, what about the outcomes? Well, he said, following the surgery, we would know whether or not we left cancer behind. But this, too, would be in free text. It'd be in another document called the pathology report. Well, what about incontinence and impotence? What about whether or not the cancer comes back? And he said, we don't track those things after they leave the hospital. He said, we would know if the patient was readmitted within 30 days. We would know if they acquired an infection while they were in the hospital. These are two things that we get penalized for if they occur. But then he said, we don't even know if the patient dies. And this, for me, was an incredible aha moment. Every organization I had worked for before I came into healthcare, their survival was absolutely dependent on their ability to improve, on their ability to get better, to use their data on a nightly basis to ask and answer the three most fundamental questions of improving anything. What are we doing? Is it working? What should we be doing? And healthcare wasn't asking, nor could they answer these questions. In fact, the few questions that we answer on a nightly basis are related to government-mandated quality measures. Important, but not necessarily relevant to the thousands of clinical questions and the thousands of decisions that clinicians have to make each day. And I realized that this field that counts the most counts the least. And so I took on that project, and in fact, I made that my career. I would spend the next several years developing technologies that could be used to answer these three fundamental questions. What are we doing? Is it working? What should we be doing? Now, these technologies have names like natural language processing and machine learning, and these days it's become popular to call all of them artificial intelligence or AI. And there's a lot of confusion and even a bit of myth as to what these technologies really are and what they do. And I'll tell you that they're just tools that allow us to learn from data, to analyze patterns, to understand what are we doing, to predict what's likely to happen, and then to customize our interventions and our recommendations specific to individuals. These are the same technologies that have been used for the last 20 years by companies like Amazon and Google and Facebook to literally transform their industries. And now the opportunity is we can use these technologies not to sell more books or ads or software, but to align individuals with the right care sooner. And so this is what I did. For several years as a researcher, I would work with quality improvement teams. I would develop these technologies. We would test them in the real world. We would publish papers showing that they could make a difference. And it was a good career, and I probably would have lived happily ever after if I hadn't had another aha moment. And that's when I realized this work I was doing to improve quality with these hundreds of organizations that I was lucky enough to work with would never really have the impact I had joined healthcare to have. It would never really be widely adopted by these organizations. And this had nothing to do with the technology. This had everything to do with the incentive. 95% of healthcare today is delivered in what's called a fee-for-service model. That's a system that we created that pays for volume and complexity. And this quality improvement work that I was doing, like nearly all quality improvement work, if successful, would reduce volume and complexity. And so I came to realize everyone I had ever met in healthcare was there for the right reasons. They, like you, spent their days doing God's work, saving lives, improving quality. But ultimately, it's the incentive of the system that dictates what the system will and will not invest in. It's incentives that decide what really counts. I'll give you an example. The airline industry has an incredibly rigorous system for counting near misses. Why? Because crashes matter so much that it's worth counting when they almost happen. In 2001, the Institute of Medicine issued a report that said that an estimated 98,000 Americans die each year by medical error. Just 2 years ago, researchers revised that number to 210,000 deaths by medical accident. That was the lower bound of their estimate. The upper bound of their estimate was 400,000 deaths a year. If that number is true, medical error is now the third leading cause of death in the US. And there was quite a debate as to whether or not that number was true. Is it 98? Is it 200? Is it 400? I listened very carefully to that debate, waiting for the most obvious and important question to be asked and answered. And it never was. And that is, why don't we know this number? None of you would argue that knowing the number of deaths by accident each year doesn't count. Of course this counts. And yet, to the system, this does not count. The system that counts the most counts the least. That's not to suggest that we don't invest heavily in information systems and data. We do. But the incentives dictate what those systems and what that data will do for us. Take, for example, your beloved electronic health records. I was at the annual conference for the Institute for Healthcare Improvement, and a doctor stood up in front of his peers and said, "Don't ever admit to your electronic health record that the patient across from you has diabetes. Because you'll spend the next 20 minutes of your life clicking your way out of EHR hell." A study came out 2 weeks ago that found that 50% of a primary care physician's day is now spent clicking away on the electronic health record. 2/3 of that time was labeled as administrative or clerical in nature. This is not a design flaw. The system works exactly as it was designed to in a fee-for-service system. The primary reason for the electronic health record are as follows. First, to document volume and complexity so that we can be reimbursed in full. Second, to protect ourselves and our institutions from legal liability. And third, increasingly, to prove to third parties that we are compliant with mandated quality measures. Every system gets exactly the results it is designed for. Imagine what these systems would look like, how they would behave if their primary reason for being was to improve the quality of care delivered. And so the $3.2 trillion question is this: how do we get a fee-for-service healthcare system to meaningfully invest in learning and improving outcomes and reducing volume and reducing complication? And the answer is, we cannot. We need a system that pays for keeping people healthy. We need a true value-based system. And I know this is not a new idea, and I know that it's easier said than done, but I do sincerely believe that the conditions to make this possible are just now happening. First, as you're all aware, there's a growing discourse about the fact that what we're doing is not sustainable. Something's got to give. Healthcare has to change in some meaningful way. That's good. We can use that. Second, if 95% of care today is delivered in a fee-for-service model, that means that the glass is 5% full. We have a model with which we can prove that there's a better way. And third, we have an explosion of data and tools like machine learning and AI that we can use to discover thousands of incremental opportunities for improvement. So what if we took your passion and your skills and we gave you these tools and this data and we laser focused it on making that 5% wildly successful? And success has to be measured in terms of both outcomes, but also financially, because this has to be sustainable in nature. Could we not then grow the 5% to 10% and the 10% to 20% until eventually we hit a tipping point? So this is the plan, and I am personally vested in it pretty heavily at this point. I left a great job at a prestigious academic medical center to form an organization. Now that organization, called Cyft, exists for one reason. It's to use data and AI to make value-based care wildly successful. And we think there are three areas that we can make a big difference for value-based care if we use the data the right way. First, we can use all of that data and these tools to match individuals to the very specific interventions they're most likely to benefit from, and sooner. So rather than waiting until someone comes into the hospital and then predicting whether or not they're going to come back in 30 days, why don't we use AI and the data to identify, for example, the older adults that are most likely to fall down in the next 2 weeks and get them in a falls prevention program so we can avoid this unnecessary hospitalization to begin with. Second, let's use the data to make sure that these value-based care organizations are being reimbursed in full and appropriately. Because if you cannot do this sustainably, it will not survive. And third, let's do customer service and healthcare differently. Let's use the data to predict who's likely to leave those organizations and go somewhere else. And if we did that, then customer service and healthcare could, for the first time, become proactive instead of reactive. So it is as exciting as it is scary. It's working, but it's not enough. We're talking about transforming a system. We need a movement. And I was incredibly grateful to have been invited here today to recruit you. So I'd ask you to do one favor. As you sit in the audience, think about the last great idea you had for improving healthcare. And listen to the speakers after me describe their great ideas for improving healthcare. And ask yourself, would the healthcare system you work for today embrace that idea? Would they nurture it? Would they invest in it? Would they surround you with the resources you need to make that idea have real impact? And if the answer is no, then consider whether or not you can help grow the 5%. If you're a clinician or an administrator, could you work for an organization that has the same incentives you do? If you've got a million great reasons to remain within the fee-for-service institution that you work for, I think that's great. Follow the money to the value-based contracts. Most have one. They're hard to find because we disguise them with acronyms and code names. They're called ACOs or accountable care organizations, or AQCs, alternative quality contracts, or bundled payments or episodic payments. But they're out there, and if you could make them wildly successful, then your fee-for-service organization would have every incentive to invest in more of those types of contracts. And finally, if you're involved in policy in any way, policy creation or policy review, please advocate for the fact that it's not just about who pays for healthcare that matters. It's about what we pay for. Let's all do this because we all need a healthcare system that counts. Thank you.